Okay, so nice to see you all here. Thank you for being here, Chris. Today we have Christopher Hopwood, professor at the University of Zurich and a well-known expert in personality and psychopathology, broadly speaking. Chris is going to summarize in a very important paper published by Clinical Psychology Review on a construct that we all use, even if not necessarily in the same way. And so Chris, Maury, and Marcon tried to offer a perspective to better understand this fundamental construct in clinical psychology, broadly speaking, that is dimension. It is at the core of a huge debate in the last 25 years at least, in assessment, diagnosis, and conceptualization. So thank you, Chris, for being here and discussing this very important topic.
Thank you for having me. I'll just share my screen. Can you see my screen?
Yes.
Yeah, cool. Yeah, so thanks again. It's a pleasure to be with you tonight. This is a kind of simple concept dimension, or it seems like a simple concept. We all kind of have an idea of what this is. Sometimes you write papers because you're annoyed. Actually, many times you write papers because you're annoyed. And for years, my whole career, I was annoyed because people would use this word in very different ways. And the differences in the way that they would use this word were really important. And it caused a lot of confusion when people would use the same word to mean different things. So in some ways, I felt like maybe this was a paper that didn't need to get written, but I was annoyed enough that I finally decided with Les and Christian, somebody has to write a paper like this. So that's where this came from. Um, the concept of dimension in psychopathology has become increasingly popular. As Simona said, I'm sure you're all familiar with the idea of dimensional approaches to psychopathology. This is just a slide that gives you an example. Over 40 years, from 1980 to 2020, how many papers published in the research literature talk about psychopathology dimension as a key word? And it goes from maybe 1,500 to nearly 25,000 during those 40 years. So what do we mean? Here are some example dimensional models. There's the alternative model of personality disorders on the top left. There's the five-factor model of personality traits on the top right. There's the high-top model of psychopathology on the bottom left. And there's the interpersonal circumplex model on the bottom right. These models are all trying to do slightly different things, arguably. They have different constructs in them, different features. But what they have in common is that they're all dimensional. They're different from categorical models like the ICD or the DSM 3, 4, and 5. In a categorical model, typically categories are polythetic, meaning you might have 9 possible symptoms, and a patient would have to have 5 of them in order to get a diagnosis. And it's categorical in the sense that either a patient has the diagnosis or they don't have the diagnosis. The topic here is, well, what is dimensional? It's not categorical. And you might think, well, if you just added up those 9 things, then you'd have a dimension. So you'd go from a category to a dimension. That would be a continuous model of dimensional. That you could sum or average indicators, and there's advantages to doing this. You get more reliable information. But part of the point of our paper is simply adding up those 9 things does not necessarily make a dimension. Another thing you could do is to see whether those 9 indicators would fit a factor model. So would the data support the idea that those 9 things are all part of one single thing? And if so, then you'd have a somewhat stricter definition of dimension. Now you'd not only have continuous variable, but you'd have homogeneous indicators of that continuous variable. So for example, the 9 items, the 9 indicators or symptoms of depression in the DSM. You have some things like sleep problems, you have interest issues, you have sadness. Are sadness and sleep problems part of the same construct, or are they different things? That's the homogeneous question. A third criteria would be whether they're distinct. So if you have, the truth is you can have any combination of 9 problems in life, and all those problems will tend to correlate with one another. That's one thing we've learned about psychopathology. So you could take a few anxiety symptoms, and you could take a few depression symptoms, and you could take even a few schizophrenia symptoms, put them on the same scale, and you might get evidence for a dimension. But would it really be different from other kinds of dimensions? So in this paper, we sort of went through these 3 different levels of increasing strictness or specificity. And say, well, these are 3 different ways you could think about dimension. And then on the right, you have some example measures that meet some definitions, but not others. And I'll come back to this slide at the end. First, I want to go through in more detail what each of these levels would mean. So this is the continuous idea. As I said, in a categorical model of depression, you might have 9 symptoms that's indicated down here in the bottom by this category bar. And if you have 1, 2, 3, or 4 symptoms, you don't get the diagnosis. There's a threshold here at 5. And if you have 5, 6, 7, or 8, or 9 symptoms, then you do get the diagnosis. Of course, the problem with categories is there's a difference between having 0 and having 4. It's arguably worse to have 4 than to have 0. There's also a difference between having 5 and having 9. If you had to choose, you'd rather have 5 symptoms of depression than 9 symptoms of depression. So you lose a lot of information by putting people into categories. And that means that your variable is less reliable, it's less valid, and you're not able to make distinctions that could be clinically important around severity. So a simple solution is just add up all of the number of symptoms a person has, and you can go from very low severity, a person has 0 or only 1 symptom, all the way up here to very high severity. You still have the threshold problem. You still have to decide where you're going to give a person a diagnosis and put that in their medical record. But now you can make distinctions both above and below that threshold in terms of how severe the person's depression is. So a lot of times you might think of dimensional this way, just adding up any symptoms of any disorder. But you could ask yourself, well, is depression a homogeneous construct? Is it one thing? Or are there multiple things? So for example, the Beck Depression Inventory is one of the most common measures of depression. When you do a factor analysis of the Beck Depression Inventory, you never get one factor. It's kind of all over the place. Sometimes you get 2, sometimes you get 3. It seems to depend in part on what population you're looking at. But from a psychometric perspective, when you have 3 things, you shouldn't call it one thing. And so simply adding up all of the items on the Beck Depression Inventory and calling that a depression dimension misses the fact that you're adding up apples and oranges and maybe bananas, depending on where you're using the instrument. So that brings us to the second criteria for dimension. You still have the continuous criterion. You still have a severity gradient from low to high, but now you fit the indicators of your measure to a factor model like this. And if those indicators are indicating a homogeneous construct, that is, if all of those things are telling you something about one thing, then this kind of model will fit the data fairly well. What this model assumes is that answers to all of these items, in this case there's 6 items, can be explained by this higher order construct. right? So the reason people say yes to that one and that one and that one is because they have high scores on whatever this thing is. And the only thing that's left over in the variance of these items is error that's specific to those items. So if a set of items fits this model well, then you can say, okay, I can summarize all of the information in all of these item response with one thing. Now, it's confusing to do that if you've got multiple things, as is the case with the Beck depression inventory. Taking a scale like that and saying that you have one single score to represent depression severity is mixing all different kinds of things together. It would be the same with most DSM categories. If you simply added up all the symptoms, say for borderline personality disorder, when we know that there's evidence that there's multiple factors within borderline personality disorder, you'd be mixing apples and oranges. And ultimately, what you'd be missing clinically is that some kinds of people with borderline personality are more externalizing. They're more likely to hurt people, be angry, hurt themselves, act out. And some people with borderline personality are more internalizing. They tend to feel empty and hopeless and chronically distressed. As a clinician, you want to know the difference between those two kinds of people. But if you put all of those differences into one score, then you lose that information. Okay, one of the big problems we have in assessment is called the jingle-jangle fallacy. The jingle fallacy is when two different scales with the same name are actually measuring two different things. So it's easy to find examples of that. The jangle fallacy is the opposite problem. It's when two scales with different names are measuring the same thing. So a good example of that would be grit and conscientiousness. I don't know if you know about this literature, but there was a big literature about grit, and it turns out that that's exactly the same thing as conscientiousness. And so having two words to represent a single thing is confusing. So a third criteria for dimension would be whether the dimension is distinct. And the only way to tell whether a dimension is distinct or not is to do this for multiple things all at the same time. This is what the high top model does, for example. Many personality models are like this, where you have kind of higher order traits like the big five, and then lower order traits. Criterion B of the alternative model of personality disorders is like this. In this kind of model, each construct at each level fits a unidimensional model, so it's homogeneous. But you can also use the model to test whether this construct is different than that one. So if this was, let's say, internalizing, you might have something like distress here, and this might be depression and anxiety. This might have something to do with eating, and this might be binge purge problems, and this might be restrictive problems, etc. And what this model allows you to do is to not only say, when I have a score on something, I know that that score represents one piece of reliable information. It also allows you to say, and this is different from a different thing. This is the chief advantage of the high top model in contrast to the DSM categories. In the DSM categories, comorbidity is common. And one of the main reasons that comorbidity is common is because different disorders have the same symptoms. So, for example, sleep problems is a symptom for multiple disorders. Mistrust is a symptom for multiple disorders. If you put the same items on different scales, those scales have to correlate. It's mathematically inevitable, right? In a model like this, you wouldn't do that. One of these constructs might be sleep problems. Now, you could still have a syndrome like depression. You could say, well, my prototype of depression is a combination of distress and sleep problems and anhedonia or something like that. But in data, those things, those symptoms of major depressive disorder don't reflect coherent constructs. They're not single things. They're multiple things that are kind of put together into a diagnosis. And when you mush them together like that, and then say people above a line versus below a line is your diagnostic decision, you lose a lot of information. Okay, so what did I just say? You can use dimensional to mean different things, and we outlined a kind of hierarchy of strictness. The least strict definition is that you can add up or average any set of indicators of diagnosis or any set of items on a scale. You can call that a dimension if you want. That's what the Beck Depression Inventory does. That's what the Hamilton Rating Scale does. People have proposed something like this for changing DSM categories into dimensions, but those would not meet psychometric standards for what we mean by the word dimension. You'd be adding up different kinds of stuff from different constructs in a way that would ultimately lose information and be confusing. A second criteria would be homogeneity. So are all of the different indicators you're using to represent whatever you're trying to measure, do they all represent one thing? So the Promise Depression Scale, which is in the DSM, by the way, does do this. All of the items strictly talk about depressions. They say, are you sad? Are you blue? Do you feel hopeless? They don't have anything about sleep. They don't have anything about sexual interest. And for that reason, they represent a single core dimension. And finally, but the problem with the Promise Depression Scale is you don't know if Promise Depression is different from Promise Anxiety unless you put it into a multidimensional model. So the third criterion would be that each dimension is distinct from one another. So I give a couple of examples of depression scales like the NEO Personality Inventory or the Personality Assessment Inventory, where this has been done, where you've got separate depression indicators. For example, on the PAI, you have a cognitive scale, an affective scale, and a physiological scale. Cognitive scale are things like, I don't believe in myself, I'm hopeless about my future. The affective scale are things like I'm sad or I'm blue. And the physiological scale are things like I don't have energy, I'm not hungry, I'm having eating problems, I'm having sleeping problems, right? So now you can have interesting configurations where you can say, well, these two people have the same level of depression, but one person's depression is mostly cognitive, they're mostly hopeless, whereas a different person's depression is mostly physiological, mostly has to do with being tired and not eating and not sleeping. And of course, this is something as a clinician that we would want to be able to tease apart, but you can't do that with the DSM category, for example. Okay, Simona asked me to keep it relatively short. That's what I tried to do. I think I only went about 20 minutes or so we had time for a discussion. This is the paper that he mentioned. In case I was confusing, you have time now to ask me questions, or you can have a look at this paper. But I'm happy to open it up now.
Okay. So thank you, Chris. If there are questions in the chat, we will be happy to translate. I will start with an initial question that is whether it is better, in your term, clinically speaking and theoretically speaking, to use a more strict definition that is including the three levels you described, or it's equally useful, clinically speaking, using just one of the three.
My own personal preference, I think the most important thing is that we are clear what we mean when we use the word so that we're not confusing when we talk to each other. Language is hard enough and communication is hard enough, but when you use the same word to mean different things, it makes it harder. To me, I would not use dimensional to describe a continuous variable. So I would not call the BDI dimensional. And I would not say that simply summing up the symptoms of a psychopathology construct would be dimensional. um, because it's not. There's more than one dimension in there sometimes, or you don't know. But if you tested it and then you found that there's more than one dimension, then I don't think it would make sense to call that dimensional because you've got more than one dimension. So to me, this has been the biggest problem in the literature is that people are using dimensional to refer to continuous variables. Like size would be a simple example. The size of a human body can come from height and weight and density. But those are different things. You've got tall people who are very thin and don't weigh that much, and you've got short people who are not very thin and weigh a lot. And to mix those things together is simply confusing. So I would not use dimensional for continuous. To me, dimensional probably could be used for a continuous homogeneous scale. Like I think it would be fair to call the promise scale dimensional in the sense that it fits a dimensional model. The distinct criterion really has to do with discriminant validity, because you could have two dimensions and you could have good evidence that each dimension was both continuous and homogeneous, but you wouldn't know if they're measuring the same thing or different things or similar things or what. So if you really wanted to have a coherent system of all of the different variables that we think about, ultimately the best system would meet all three criteria. So to me, I would say anything that's continuous and homogeneous could be labeled as dimensional, but until it's also distinct, you still have problems.
Okay, thanks. Because you're really right. It opens up otherwise to a very huge chaos of different labels. Implication and continuity is easy to be applied to a variety of different constructs, losing the core meaning maybe. Another big question is, as the clinicians, we may ask whether in case conceptualization and treatment planning, what do you think are the major advantages of thinking about psychopathology in such a dimensional way, such a dimensional terms?
Yeah. I think there's two. One of them goes back to just the continuous idea. You just lose a lot of information if you take a dimension, a continuous indicator and turn it into a category. So if you said you can only have two kinds of people, tall people and short people, you would lose a ton of information because there's a difference between being close to average and being very short or very tall. So to me, this is, I understand that we have to have diagnostic thresholds. You have to classify people as either having a diagnosis or not. But as a clinician, you want to know more than just whether they're in the category. You want to know how severe the person's diagnosis is if they have one. And if they don't, you want to know if they're at risk or if they're not at risk. So to me, categories just don't make a lot of sense. And I don't understand why the field still uses them. I think most of the research community has stopped using them 2 decades ago. Um, and yeah, I can't make a good argument for why should we should lose information that way. The other thing though, so I was actually working with an Italian colleague last week, and they have a data collection in their clinic. And I was talking with a student about like a research project using these data. And we wanted to see, well, how does this scale correlate with that one or whatever? And I said, boy, you measure one thing a lot. You have like 15 scales, but they all kind of measure similar stuff. And I said, let's look at the items. And we looked at the items of the 15 scales, and the word worry came up in multiple questions across all of the different scales. And I said to him, like, how many times do you want to ask people if they're worried? Like, wouldn't it make more sense to just ask them one time or with maybe even several questions, but all within one scale? Like, how much do you worry? Rather than there's a measure of obsessive compulsive worry, and there's a measure of generalized worry, and there's a measure of negative affectivity as a personality trait that has worry in it. There's a measure of coping that has to do with worrying. It's like, why would it make sense to put that question about are you worried in all 15 of your scales? All that's going to happen is if a person's worrying a lot, all of their scores go up. And if a person doesn't worry very much, all their scales go down. But what's the point of giving 15 different scales if they're all going to go up and down together? It's a waste of time. And I have to tell you, if I'm the patient, I'm like, why have you asked me 85 times if I'm worried? Like, what do I need to answer this question so often for? But I think this is common if people don't think about the ways that they're measuring things in a way that's represented on this slide. You might think, well, I care about obsessive compulsive problems and generalized anxiety, and I care about depression, and I care about personality, and I care about all these different things. And you might not ask yourself, but are those things really different? If you use a model like this, then you can test whether or not they're different. And what would happen in a model like this is you'd have one construct called worry, and you could ask that about worry 4 or 5 different times, and then you get one score. But then you wouldn't be mixing it up with all these other different constructs. So this would say, number one, this would save you a lot of time. Number two, it would save the patient a lot of time. Number three, it would make it so that each piece of information that you got was maximally different from each other piece of information that you got. So you get a lot more bang for your buck, right? You get a lot more information with a lot less effort if you use multidimensional models to try to figure out what you wanted to know about people.
Yes, I fully agree. Thanks for this. And I would kindly ask you now if you can elaborate a bit about, I guess, another important elements related to using dimension psychopathology that is related to implication for treatment planning and clinical trials in the sense of how much we run the risk to miss the implications of comorbidity between categories and heterogeneity within a single category that maybe using the Occam razor may explain a lot about missing clinical utility and effectiveness of many randomized control trials where we simply maybe are targeting something that is not consistent with what we are offering or what the client is asking for.
Yeah, no, this is another thing that it's not my area, but it's annoying enough that I thought about writing a paper about this. Many other people have written a paper about this because they're annoyed. Um, the field has been doing randomized control trials with people who all belong to the same diagnostic group for what, 5, 6 decades? Certainly all of my life, all of most of your lives. And that has gotten us nothing. Like we've learned almost nothing. We've learned that anytime you use an intervention that's designed to work, it's better than not doing an intervention. And we learned that anytime you do two different interventions that are both designed to work, they work about equally well. So, like millions and millions and millions of euros and careers and patient time and hours of research and journal articles have gone into learning almost nothing. So you ask yourself, well, one possibility is that every intervention does work okay and about the same as every other intervention. But another possibility is that the design isn't very smart. So we don't know. It could be one or the other of those two possibilities. But I think your question, Simone, has to do with the possibility that the design is not so smart. Well, what would be wrong with that design? If you select people for an intervention, let's say of depression, and let's say you want to compare interpersonal and cognitive behavioral therapy for depression. And the people who are doing each treatment both think that their treatment should work. So it's a fair test, right? They've done this many times and every time they tie. So it doesn't matter. Why might that be? Who are the people that are in the intervention, right? They all have to have at least 5 symptoms of major depressive disorder. But some of them might uh, have these 5 symptoms and other have these 5 symptoms, and only one in common. That's the problem of heterogeneity. Now, if you believe that your treatment targets something specific, like if you're a cognitive therapist and you think, well, my treatment targets the way people think, and half of the people that you get don't have problems with thinking, their problems have to do with sleeping and eating and whatever, then it doesn't make a whole lot of sense that that treatment would be effective for a problem that a person doesn't have, right? So the heterogeneity problem creates a lot of disconnect between whatever the specific mechanisms of the treatment should be and whatever the specific problems of the patient might be. You've also got the other problem of maybe some people are depressed, but they also have substance abuse problems. Some people are depressed, but they also have personality problems. Some people are depressed and they also have post-traumatic stress. Well, if you have a patient that has 5 different diagnoses, how do you know that intervening on depression is the right way to think about that person, right? I think as a clinician, we wouldn't necessarily assume that. For example, most clinicians think if a patient has both depression and substance use problems, first begin with the substance use problems and then see where you're at. And if they're still depressed, then move on to the depression after that. So what you can do in a randomized control trial is say, okay, well, anybody who has anything other than depression, I'm not going to include in my study. So these people have to meet criteria for depression, but they cannot have any other diagnosis. This is the way you might do it in a medical trial. The problem is, how many patients have you had that have depression and nothing else? It's actually not that common. Typically, people who have major depressive disorder would also meet criteria for an anxiety disorder or some other disorder at the same time. So now you're dealing with a very low severity part of the depressed population who doesn't represent the kind of people that you would typically see in a clinic. And you still have the heterogeneity problem. So basically, what's happening is you have kind of fuzzy treatments. It's not clear what the difference is between cognitive behavioral therapy and interpersonal therapy in the first place. You have very fuzzy patient groups, or you have very non-representative patient groups. It shouldn't be a super big surprise that the results are themselves pretty fuzzy. Like we haven't learned very much from that literature because it's not a very smart way of asking the question. If you used a model like the one that you see on the screen now, you could try to map specific interventions to specific constructs. You could say, well, this particular intervention is designed to deal with sleep problems, and this particular intervention is designed to deal with hopelessness, and this specific part of the intervention is designed to deal with energy issues or whatever. And then you could mix and match interventions in a principled way to see if the specific part of the intervention designed to deal with that construct is actually moving that construct up and down. You wouldn't need to pick people who are all in some groups. You could just pick anybody who's in psychotherapy, and you would allow the natural variation among those patients to be represented by a model like this. And then I think we might have a shot to learn something specific about how interventions work. It could be that they all work the same. That would be my bet. But at least this would be a principled way of testing the question.
Thanks, Chris. I would have other two big questions. One is, I know it's a very huge one, but if you can summarize what we know about the variability and utility of dimensions, I would say over time. I mean, in the life history, in the life trajectory of
Sure.
patients, of persons. So not just here now in the assessment.
That is a big question. Well, one thing that I think I mentioned before, but I can tell you is that because you don't throw away useful information, there's a meta-analysis by Christian Marcan, who was also a co-author of this paper that we wrote. In his meta-analysis, I think you lose like 40% of reliability and 50% of validity or something like that, simply by going from a category to a continuum. Forget whether it's a dimension or not, but just using symptom counts rather than categories, you gain 50% validity and 40% reliability. So it's a lot easier to ask that question if you use continuous scores. We know, we know a lot about stability and change in higher order dimensions of individual differences across the lifespan, mostly from the personality literature. So that's like the big five, for example, which is this picture up here: neuroticism, extroversion, openness, agreeableness, and conscientiousness. And you might think to yourself, well, what does that have to do with mental health problems? It turns out if you make a factor analytic model of all the different mental disorders, which is what Hightop does, you get traits that are very similar to these big five. So internalizing is very similar to neuroticism, antagonism to low agreeableness, disinhibition to conscientiousness, etc. So you can use the massive literature on stability and change across the lifespan from personality to make inferences about stability and change in psychopathology over time. So what do we know about that? There's different kinds of stability, so I guess that's the first thing to talk about. One kind of stability is called absolute, and that means how do scores on average in a population change over time? So are like 30-year-olds different from 20-year-olds on average? Or on average, if you go from being 20 to being 30, how is your personality and psychopathology likely to change? What we know from that literature is that there are changes over the lifespan, number one. Number two, most changes happen during the transition to adulthood. So from around the time puberty begins to maybe 30 years old or so. Um, and number three, those changes tend to be in a more adaptive direction. So people become less neurotic, more agreeable, more conscientious. Um, and This tracks with what we know about prevalence estimates of psychopathology. Psychopathology rates also tend to peak in early adulthood. Not every kind of psychopathology, but certainly the most common disorders, depression, anxiety, psychotic disorders, substance use problems, are most prevalent in young adulthood during the time that people's personalities are maturing. So that tracks pretty well. A different kind of change is rank order change. This is like what a correlation tells you over time. That tells you if you've got four people at time one and they go through time, will they be in the same order or will they switch? Will one person that was low before be high? So this is like if your sister is more extroverted than you today, will you be more extroverted than her tomorrow, or will those differences persist over time? Um, Rank order stability tends to be pretty similar across the traits and pretty similar across the lifespan for the most part. And psychopathology and personality are both pretty similar to each other. So on average, if you measure people a year apart, on average, you're going to get about a 0.6 correlation. So people who are more depressed than their neighbors today, a year from now, are pretty likely to be more depressed than their neighbors tomorrow or a year from now or whatever. There's a few other more kind of idiosyncratic kinds of stability and change that maybe I won't talk about. But another interesting kind of study has to do with what happens when major life events occur. So um, if you were to get divorced or retire or get a job or have children or experience some kind of immigrate to a new country or have some other kind of major life experience, what does that do to you? And the major finding there is that the findings are pretty inconsistent. In fact, most of the evidence is actually that certain kinds of people are more likely to have major life events. There's less evidence that people who have certain kinds of life events change in particularly systematic ways. So, for example, people who are more antisocial and depressed are much more likely to get divorced. But getting divorced doesn't necessarily make it more likely that you'll be depressed or antisocial after the divorce. Or um, people who are less, people who are depressed are less likely to have children. And actually, there is some mild evidence that women who have children become a little bit more depressed right around the time they have children, but then they kind of come back. Um, so it seems like individual differences in psychopathology tell us something about what kind of things will happen to people in their lives. But the fact that something important happens in people's lives doesn't tell us on average how they'll be different afterwards. Of course, for an individual person, major life events can have a huge impact. But in the average, on the aggregate, knowing that somebody retired, for example, doesn't tell us much about what they're going to be like or how they'll change after that event happens.
Okay, thanks for summarizing 20 years of
It's a lot.
research in 3 minutes. I would have a final question that is more a comment of you about what is your gut feeling, explaining hypothesis about why it's still so difficult to to have this kind of dimension-based approach more common in several areas, from diagnostic system to university programs, and finally, to organizational research grants and so on. So
Yeah.
again, I would not expect you to again to offer the ultimate answer, just a comment on.
Yeah, I mean, I've certainly spent time thinking about this. I was involved as a PhD student in most of my career with this model, the alternative model of personality disorders. And my advisor, Les Morey, who was also a co-author on the paper that we just talked about, he was on the work group that made the alternative model of personality disorders. And this was like 2007, 2008 that we were working on it. And of course, the book was published in 2013. But for 5 or 10 years before that, we were working on this, and they were told by the APA, the American Psychiatric Association, they were told, like, look, everybody knows that personality disorders are not categorical. Like, this is obvious. Like, there's no question about this. But like it's hard. So we want you to really be the foot in the door. And everyone knows that psychopathology in general is dimensional. So we really want personality disorders to be the foot in the door. We want you guys to make personality disorders dimensional, and that will then enable the rest of the diagnoses to also become dimensional. And so that's what the alternative model was supposed to be. And at the last minute, the American Psychiatric Association Board of Trustees had a conservative spasm, and they said, no, 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 we have to have categories because people are used to them or whatever. And so we're going to make this an alternative model rather than the new model. And this is going to become the model soon. In the ICD, it already is, or something like it. So that happens. Eventually, I think all of psychopathology will be dimensional. I think this is clear. I don't think this is really a question for debate. It's just a question of how long. So your question to me was, why is it taking so long? Yeah. One issue is habit. It's there's inertia. It's just hard to change people's minds. If you were trained a certain way of thinking about things, then you need really good reasons to change the way that you do things. Um, there are people whose careers are based on certain categories. So I know that in the personality disorders, there was a bunch of people who were against getting rid of the categories, and those people all had published extensively on things like borderline personality disorder or narcissistic personality disorder or whatever. So that they had a kind of conflict of interest, I would say, that they wanted to keep the categories because their careers, their legacies were based on the categories. Um, there are practical challenges, right? Like you have to change the way you do assessment. You have to change the way insurance is processed. You'd have to change the way clinics function. You have to reorganize the way we think about interventions. Like it has a lot, the courts and the legal system would be affected. So there's like a lot of implications that would need to be thought through. And it's fair to be slow to make sure that you've done a good job thinking all those things through before you make a big change. And I think another thing is that for most clinicians, diagnosis doesn't matter anyway. Like I think for a lot of people, they say, well, I make a diagnosis because I need to do that to justify like insurance or to tell the patient something about what I think the problem is. But ultimately, I then go to my favorite theoretical perspective and I make a formulation and treatment plan based on my theory, not based on whatever the DSM says. So I think there hasn't been much interest in the practice community to make a change. And I think, and my feeling is it's because most psychotherapists don't care about diagnosis one way or the other. And so it could be categorical, it could be dimensional. What difference does it make? I think is part of the issue.
Yes, that's the a sort of paradox because psychotherapists at the end want to know how the passion works, functions in their daily life. Um, but again, it's really thank you for this marathon in 40 minutes, 45 minutes to summarize a very important topic and all this implication. I guess it's very important also to go on disseminating the relevance, the validity, and the huge experimental background, because sometimes we forget that it's not a matter of Chris or Simone's opinion. It's a matter of at least 30 years of research. So thank you very much, Chris, for this wonderful webinar. Thank you all for having joined us. Hope to see you soon.
Yeah, thanks everyone for coming, and sorry to the translators for talking too fast.
Okay. Thanks again, Chris. Thanks.